Right, I have a pleasure to introduce Ms. Harrington. She is my consultant aortic surgical colleague who was appointed about a year ago. And she worked with Professor Bounce, late Professor Bob Bouncer, and did the research on the cerebral protection. So she's by far the best candidate in this room to present this topic. Ms. Harrington.
Thank you. It's an honour to be amongst such esteemed company today. And I'm not going to talk a lot about my own work, but really I'm using this more as an update, I think, really, in sort of cerebral protection and what's sort of happened in the past few years. So we know that hypothermic circulatory arrest has been the mainstay of cerebral protection for aortic arch surgery for many years now, popularised by Randall Greep in the 1970s. And the main premise of this was that profound hypothermia would cause a reduction in cerebral metabolic requirements, allowing total circulatory arrest and thus construction of a distal anastomosis and also arch anastomosis. However, we know from animal experiments that the cerebral metabolic rate for oxygen does not completely get abolished, even at profound hypothermia. It's only reduced to about 87%. And there are clinical time constraints. We know that after about 40 minutes, the incidence of stroke goes up and the mortality goes up significantly after about an hour of circulatory arrest. So various adjuncts have been... how do I go next? Yeah, sorry. Cerebral protective adjuncts were developed in order to try and extend the length of time that could be used for the arrest period and to make surgery safer. Retrograde cerebral perfusion was initially used as an emergency treatment for massive air embolism back in the 1980s. And this uses perfusion via the SVC. And its potential benefits are that it may flush out debris and emboli, that it may maintain intracranial hypothermia, and that it possibly may provide some cerebral perfusion. And this was taken up by many groups, popularised initially by Ueda and colleagues in Japan, but then used in a widespread fashion throughout the world. Selective antegrade cerebral perfusion was originally tried back in the 1950s by Dr. DeBakey, and it was abandoned at that time because of the concerns about emboli and instrumentation of the head and neck vessels. And however, a resurgence of interest occurred, mainly led by Kazui in Japan, but also in Europe by Jean Bachet and Roberto Di Bartolomeo, who all have produced huge series of patients with excellent results. And they've all used different ways, but essentially selective perfusion of one or more of the head and neck vessels. And this is intuitively more physiological, and there's a possibility that it may not require profound hypothermia and thus the prolonged bypass times that are otherwise required. So my background to this was, we performed a randomised trial between antegrade cerebral perfusion and standard circulatory arrest, and it's over a decade now since I stood here in Edinburgh and presented that work. And we did show that there was a metabolic benefit in the antegrade cerebral perfusion group, so I have to say that, I am a proponent of antegrade cerebral perfusion. However, we still had a mortality rate of 7% in that study. We had a stroke rate of 4.8%. 14% of our patients had a significant transient neurological deficit, and the vast majority of the patients still had a neuropsychometric deficit. So there were still improvements to be gained. And my question really now is, where are we now? What has happened since then? In the decade since then, what has happened? So I've looked at the literature to see where we are really. And my question, since I've been appointed recently, I've got three sort of categories of patient that I want to protect the brain for, really. Elective hemiarch replacement, and these are probably most of the cases that I'm doing at the moment, where I know I can do have a relatively short arrest duration. Elective total arch replacement, where unfortunately I am not as quick as either Dr. Safi or Dr. Eleftheriadis, and I know that I need a fairly prolonged period of ischemic time. And then acute type A aortic dissection, which, as we know, can be quite variable. And again, we may need a prolonged cerebral protective time. So I looked at the literature. And if you look at hypothermic circulatory arrest, Dr. Eleftheriades has published an excellent series of results using standard hypothermic circulatory arrest. Elective mortality is only 2%, very low rate of stroke. These cases only had a mean circulatory arrest duration of 31 minutes though. Interestingly, there were no differences in terms of the incidence of neuropsychometric deficit between the standard circulatory arrest cases and the non-HCA cases. But it was noted that patients who had a duration of circulatory arrest over 40 minutes did have a neuropsychometric deficit. If we look at circulatory arrest with retrograde cerebral perfusion, Dr. Safi has a huge series of patients whereby he has used retrograde cerebral perfusion for the vast majority of those cases. Mortality is good, and in the patients with normal renal function, mortality is only 3%. The incidence of stroke is very low, and the incidence of stroke in cases with prolonged circulatory arrest with retrograde cerebral perfusion is very low at only 1.7%. However, my feeling is that, certainly in my hands, I would not be able to produce those sort of results, and certainly antegrade cerebral perfusion, for me, I would feel is probably the way to go. The Japanese are still using both techniques as well. Yuzui has compared antegrade cerebral perfusion and retrograde cerebral perfusion and has actually found no difference in a propensity score matching from the Japanese database, and has found no difference in either mortality or stroke between antegrade and retrograde cerebral perfusion. He did, however, find a higher incidence of transient neurological deficit in the retrograde patients. So I looked at antegrade cerebral perfusion. There's been a massive increase in the number of people using antegrade cerebral perfusion, and there's been lots and lots of papers over the past decade looking at all the different aspects of it. And I've tried to kind of hone it down to some key aspects, really. So Okita, this is a Japanese paper, looked at total arch replacements, 438 patients, a big series, and has a very good hospital mortality rate of only 4.6%, a rate of stroke of 5%. Urbanski has looked at 131 patients, all elective, no acute dissections, with a mortality rate of only 2% and a permanent stroke rate of less than 1%. These are all excellent results. So what about temperature and antegrade cerebral perfusion? One of the big questions is it possible to go warmer? Is it possible to not have the prolonged bypass times that we know we need with hypothermia? Urbanski again has looked at different temperatures according to the anticipated duration of circulatory arrest. So this was not a randomized study, but he looked at cooling. If he was only going to anticipate a very short duration of arrest, so 15 minutes, he only cooled to 32 to 34 degrees centigrade. If he was anticipating a bit longer, it's about half an hour, then he would cool a bit more to 30 to 32 degrees centigrade. And if he was anticipating a prolonged duration of arrest, he cooled to 28 to 30 degrees. The SACP was always performed at 28 degrees centigrade. And these papers showed a fantastic mortality rate of only 1.2%. There was a permanent stroke rate of less than 1%. And interestingly and importantly, there were no incidences of paraplegia. There was one episode of mesenteric ischemia. A combined German series from both Frankfurt and Bad Neustadt looked at over 1,000 patients, this time including type A dissection emergency patients as well. And they performed surgery at mild hypothermia, so between 28 and 32 degrees centigrade, and had a mortality rate of only 5%, permanent stroke rate of 3%. But significantly, there were 3 patients who had paraplegia from this series. Caselli has reviewed their data from Houston, and they looked at, again, it wasn't randomized, it was a retrospective study, but they compared their deep versus moderate hypothermia in 221 patients. They looked at patients that had undergone arrest with a mean temperature of 16.8 degrees versus the more moderate hypothermia of 22.9. And interestingly, the mortality was significantly lower in the moderate group, and the stroke incidence did not actually reach significance. A further series from Japan also looked at comparing two groups. Again, it wasn't randomised, but they studied two groups of patients, one below 28 degrees centigrade and one above 28 degrees centigrade. Mortality and stroke was very similar in both groups. They did find less post-operative renal and respiratory impairment in the warmer group. Interestingly, there were 2 episodes of paraplegia, both of which were in the cooler group. However, they both had extended circulatory arrest times, and one of which was at 25 degrees and one of which was at 27 degrees. And I think this is certainly a concern. And finally, from Emory, they performed a propensity study looking at 500 hemiarches, where they compared 28 degrees versus 24 degrees. And they found that really the mortality was equivalent between the groups. The permanent neurological deficit was, again, increased in the moderate group. They had no paraplegia in this study, but the mean arrest times were only quite short at 25 minutes. So, what about technique of antegrade cerebral perfusion? Is there a difference between unilateral and bilateral antegrade cerebral perfusion? Unilateral is obviously easier to perform, especially if you've got axillary cannulation. You don't really need to do anything else. And this has been looked at by many studies, one of which was recently published in JTCVS. And they found no difference in mortality between the two groups. However, there was a trend towards an increase in stroke in the bilateral group, and they were concerned that this might be due to manipulation of the arch vessels and head and neck vessels. But extremely recently, just published, is this large meta-analysis of over 5,000 patients looking at 28 different studies comparing unilateral and bilateral antegrade cerebral perfusion. And essentially, there is no difference in terms of mortality or stroke or transient neurological deficit between the two techniques. What about other characteristics of antegrade cerebral perfusion? So looking at things like pressure and flow. There are very, very few clinical studies looking at these two parameters. They're all basically animal studies. If you look at Halstead's work in a porcine model, they did antegrade cerebral perfusion at 20 degrees centigrade, and they used 3 different pressures, 50, 70 and 90 millimeters of mercury. They found that metabolic suppression was similar for all of the groups, but there was inferior recovery with a raised intracranial pressure in the 90 millimeter group, and so that is probably too high a pressure. It will cause cerebral edema. 2 groups have looked at flow characteristics. 10 mils per kilo per minute is normal brain blood flow in an awake patient. And so traditionally, that's kind of what people have used really, without knowing any better for antegrade cerebral perfusion. But there isn't really any evidence. This group looked at 8 mils per kilo per minute versus 18, and they found equivalent metabolic suppression, but they were concerned about a luxury perfusion at the higher rate with, again, cerebral edema and high intracranial pressure. Johnson and colleagues have looked at reducing the flow to see what the minimum required flow would be to still provide metabolic support. And they reduced flow from 8 to 2 mils per kilo per minute and found that below 6 causes a reduction in venous saturations and an increase in the lactate. So, my conclusions from this were, well, and this is, we've recently started to change our practice in Liverpool, and we now perform elective hemiarch surgery at a core temperature of 28 degrees centigrade. We've only recently started doing this. We do perform bilateral selective antegrade cerebral perfusion at 20 degrees during these cases. And we do use near-infrared spectroscopy for monitoring, and we use a flow rate at between 6 to 10 mils per kilo per minute. For elective total arch surgery, we have a concern about the small but significant incidence of paraplegia that is reported in the cases where people have gone warmer. So we are currently still cooling people to a core of 22 degrees centigrade. That's measured at the bladder. We're using bilateral selective antegrade cerebral perfusion at 20 degrees centigrade for those cases. And for acute type A aortic dissection, we're still cooling to 20 degrees core temperature. We are fortunate in that our perfusion setup allows us to have both retrograde and antegrade cerebral perfusion. And so we do still use retrograde cerebral perfusion sometimes in dissection, and we find that that's useful for the flushing out mechanism. And also, if we have concerns about cannulating dissected head and neck vessels, that can also be useful. But we do also have the setup for selective antegrade cerebral perfusion. And then if we're concerned about a prolonged duration of repair, then we'll use antegrade cerebral perfusion. So I think my conclusion really is that I think it is important to now individualise cerebral protective strategies according to both personal experience and also your own centre's experience. We still need prospective randomised trials. There have not been any of these really in cerebral protection for a few years now, and most likely these are going to need to be multi-centre because of the numbers involved. Thank you.
All right, Debbie, before anybody get a chance, may I ask one question? Now you've done the research and you've done some cases as well. And what do you think about perfusion lower body? Why are you protecting the brain? Is there any extra protection for the spinal cord or not? Because now spinal cord protection is becoming an issue in the warmer kind of arch surgery.
I think my feeling is that at the moment, if you're going to have a prolonged rest duration, hypothermia is still the mainstay. I think that is still, if in doubt, cool is still the kind of maxim. I think really. I know people have used separate body perfusion and so on when you're doing an arch replacement. My feeling about that is that it's possibly a little bit difficult technically to have another cannula in there when you're trying to do a distal anastomosis, for example. So I think my own personal feeling is that it's still better to cool if you're going to have a prolonged period of arrest. And I think that in the vast majority of cases, the lower body will be safe if you cooler.
Okay. Any other questions?
It always intrigued me that the core temperature did reflect the brain temperature. I mean, the brain temperature, nasopharyngeal, and I still read in the literature, people check the rectum temperature, which is, you are going to protect it, but you're not going to protect the brain, and it's nothing new, because in the 40s, our friend, the Canadian, used the monkey to study it. When you reviewed this about antegrade, do they say what's the nasopharyngeal temperature? Because yes, you are keeping the core temperature 28, but you are perfusing the brain with temperature, low temperature.
It's variable, actually. It's not all of the people. That's another problem actually with the studies in cerebral protection, because there's no consistency in the temperature that people use. And another piece of work that we did in Birmingham many years ago now, we did look at nasopharyngeal temperature and the lag of other temperatures, and there was a considerable lag between nasopharyngeal, which did best approximate brain temperature.
I'd just like to commend to the audience a technique that was brought to us by George Matalanis from Melbourne, who came to do a sabbatical with us this summer, and I don't think we taught him anything, but he definitely taught me something, and I think he went up to Liverpool as well. This branch-first technique for aortic arch replacement, which I've now performed in 6 patients with normothermic bypass. You start with femoroatrial cannulation. It has the great merit that you then have in effect a separate perfusion circuit for the upper body, which you introduce progressively as you anastomose each of the arch vessels. I've had one catastrophe of a patient who ruptured her descending aorta into the esophagus 2 weeks post-operatively before she could have that stented. But it has the great merit of standardizing the approach for aortic arch procedures, eliminating the discussion about which technique of cerebral protection is better, which technique of cannulation is better. You can end up doing the same operation in every case. Now, George, I think, is due to present this in New York in a month's time. They must be up to 50 or 60 cases now. We're a long way off getting to the, as they do, something like 30% of patients that aren't even transfused, let alone have any other issues pending their aortic arch surgery. But I really would commend everyone to take a look at it. It's written up in the annals of cardiothoracic surgery. There's a great movie that goes with it, and it's a very appealing technique.
One problem with that technique is when everybody will adopt it as a universal approach, to me, is if you're doing on dissection, you start with the femoral, and then you started your, and then there may be some proportion of patients who will have a malperfusion and related problems, and that's one thing that it worries me. And second thing, if the arch got significant disease in the arch with the disease and calcium, sometimes not so easy to manipulate branches without causing the embolization here. Yeah.
This is complicated surgery.
That's right.
We know everything we do is in some way a compromise of one goal against another. But it has certainly simplified my thinking. I'm going to encourage people to come do more sabbaticals.
Any more questions?
I think we should move on, actually.
Just a very quick comment. Two of the things I try and teach my registrars about aortic surgery is that it's probably not, or try and avoid putting blood backwards through the aorta. The other one about neuroprotection is that cold is always better than warm, but you presented some data that may not be the case, particularly the Caselli paper. Can you just perhaps speculate why perhaps colder may not be better?
I think it is possibly due to things like bleeding and coagulopathy and so on, which was what we were thinking about when we did the randomised study, but we couldn't show it. So I think it possibly to do with numbers, you know, in large series of patients you might show it. But that's my thought, really.
Thank you very much indeed. Thanks, Debbie.